I believe right now we're live. This is American Surgery Center and CHRIAS. Today is September 23rd, Wednesday, 6 p.m. My name is Kemal Erkan. I am here with Dr. CHRIAS at the Surgery Center. We are going to discuss, this is our bariatric education series. We have done 5 of them, I believe, so far. We are picking different topics every week, and then we try to bring everyone on the same page. I will ask someone from my team, from my office, if they can just verify if everything looks good from the Facebook side of it. I'm able to see it. I just want to make sure they are able to just confirm that. So again, what we'll do today is I'm going to actually just bring up my screen. So this is the bariatric program at American Surgery Center. This is in partnership with CHRIAS, and we have, our topic is going to be why patients drop out the bariatric program. And in case you missed it, my name is Kemal Erkan. I'm the chairman of American Surgery Center, and we have our famous Dr. Isaias Irgau with us. Dr. Irgau, if you can please introduce yourself.
Hello, everybody. I'm Dr. Irgau. I'm a bariatric surgeon. I'm the president of CHRIAS, the Christiana Institute of Advanced Surgery, and I'm delighted to be here, Kemal, as usual.
Thank you for being with me, Dr. Irgau. So the one of the issues, as it's really extremely important for everyone, is why we are doing it. So from our surgery center standpoint, we want to make sure that we can make a difference in the quality of care that we are providing for our patients. ASC, American Surgery Center, started with CHRIAS, and Dr. Erkan and I, we started the program in 2018. Surgery Center goes all the way back to 1999. We took over in 2015 on our bariatric program. Although we are the bariatric program in Delaware, our surgery center portion of that started in 18. So the part of the issue that we have to really understand what it is and why bariatric is important is these are, of course, in my opinion, part of it is the experience, what makes it better if we have the right surgical team. And I do say, I'm sure I'm a little bit biased, but we have the most experienced bariatric group in Delaware. And I don't know, Dr. Irgau, if you can maybe elaborate that a little bit, and if you agree with that, and why we would be, this wouldn't be a biased opinion rather than the reality.
No, that's absolutely correct, Kemal. We started the modern type of bariatric surgery way back in 2001, myself and Dr. Gail Wynn, introducing the laparoscopic approach to gastric bypass, introducing the gastric band, the laparoscopic sleeve gastrectomy for the first time in our state. We set up and established centers of excellence in bariatric surgery in the area's leading health centers and hospitals. We have been doing bariatric surgery since 2001. We have done over 7,000 bariatric surgeries over the years. As I said, we started it with myself and Dr. Gail Wynn, and we've been joined since then by Dr. Michael Peters, Dr. Rahul Singh, and Dr. George Ibrahim. And as a group, we've done the most of bariatric surgery. We have the most experience without any question in bariatric surgery in our area.
Thank you, Dr. Now, from the surgery standpoint, now most general surgeons who actually, of course, you have to be a general surgeon before you can actually do the bariatric surgery. But when it comes to the surgery itself, it becomes a little bit more complicated in terms of how our patients are accessing to this. Now, although the risk is not any higher than any other general surgery, bariatric has been treated differently from the medical community and from society itself. Now, obesity states, I'm able to use this this slide that you see. 2019, this is about 40% of our population, and 36% from 2008. In our state, our home state, Delaware, this is one of the top three medical conditions that we have. Now, overall, the issue of whether or not this is a real chronic illness or not, and then getting overcoming that problem, then now getting the patients, educating them, making them understanding. There are several issues, and then there's the insurance part of this, where now we are actually we were having some issues with the coverage, for example. So some insurances were not covering this. But reality is this is extremely hard from a patient standpoint. Now, although I'm not a surgeon, I'm part of the program, and I do case conferences with our team, along with Dr. Irgau, our care managers, care coordinators, our facility managers. And every day, we at least go through 20 to 20, and we repeat that every weekly basis. So I can actually see how this will go. Now, and why is it being discriminated from your side?
Kemal, I think I lost you a little bit with the audio there.
Are you hearing now?
Yes, it was breaking up a little bit when you were just talking a few seconds ago.
What is the discrimination that we have on Bariatric? We have the insurance companies, we have the medical community, we have the society. Once we overcome some of those problems, this is still so hard. And I was just giving the background on why I have a really clear understanding of this issue, even though I'm not a surgeon. And I wanted to make sure that our patients, our audience understand why we are so clear on some of the issues, that we do our daily case conferences with myself and our care managers, care coordinators. So, but it is still hard to get patients to follow through this. And I was just asking from your side, your perspective of why this is so hard.
Absolutely. So first of all, Kemal, as you correctly said, the leading causes of mortality and morbidity in our country are cardiovascular diseases, cancers, and metabolic diseases like diabetes. All these three conditions are very closely related to obesity. The rise in obesity that you showed in your previous slide also means the exponential rise in these diseases that make life miserable because of the morbidity, but also shortened life expectancy. Dealing with obesity as a central problem when it comes to dealing with these diseases makes sense. And so far, bariatric surgery has been shown to be the most effective treatment we have for morbid obesity, obesity that has reached really very high levels, creating heart disease, high blood pressure, diabetes, sleep apnea, and being a risk factor for many cancers. When this treatment has been proven and is present, and there is tons of data demonstrating this, it is still very hard to get insurance companies to accept that patients need to go in an expeditious manner through the preparation so they can have this surgery. And yet, without any data whatsoever, we have insurance companies mandating a waiting period of 6 months. You have to wait 6 months doing nutritional counseling once a month for 6 months before you can qualify for surgery. It almost is a rite of passage that is demanded on these patients, as if they have to prove something in order to get a treatment that is so important for them. What other disease is treated in this manner? None. If you have lung cancer, you are diagnosed, you go to surgery. If you have morbid obesity, you're diagnosed, you have high blood sugar, you have hypertension, you have heart disease, you need treatment to take care of the morbid obesity, you have to go through this waiting period. That is the main problem we're having. Now, when you ask people to have to go through all this time, then it is very easy for them to drop out, either because life comes through and they cannot really manage to go through all these appointments, or other things happen that they become discouraged, right? So patients know that, and it requires a tremendous amount of drive on their part to be able to go through this, but they shouldn't have to. Now, having said that, I am not saying that the preparation that we have is not necessary. Preparation is important. You have to have nutritional counseling, you have to have psychological evaluation, you have to have medical evaluation to optimize your condition so that you can go through the surgery safely. All that should not take 6 months. It should not take a year. That's the point I'm making. It should be left up to the programs to determine what kind of preparation a person needs, as opposed to giving arbitrary mandates that you have to wait this many months or you have to jump through these hoops in order to obtain bariatric surgery. That is our main problem.
As you were kind of going through this, and by this time, everyone who are following us, they know our structure, and you and I, we spent a lot of time together on the clinical issues. We also had, we have gone to so many different conferences on this topic, and you know, the part of the issue that I have a difficult time to overcome is most of the people, they just don't understand when we say bariatric surgery, they are under the impression that we are trying to get everyone doing surgery if their BMI is 27 or their BMI is 29 or 32. So this is not what we are talking about. And you and I remember one of the conversations we had, like we said, well, I mean, on the clinical side, of course, you provide a lot of education for us and for me personally. When we said patient with 54 BMI, we had like 2 of them dropped out this week. And one of them was 57, the other one was 54, if I'm not mistaken. And today I'm home in the home office and I had the printouts. I just want to use some of the statistics. But the issue of this BMI 54, for example, can you just kind of give us that picture of what that patient looks like and what their situation is?
Absolutely. So BMI essentially is a number that is calculated by putting the height and the weight of the person together, right? So there is a normal BMI, which is anywhere between 18 to 25. And then there is obesity, which is defined by a BMI of 30. And then there is morbid obesity, which is defined by a body mass index of 40 or greater, right? Now, to get to a BMI of 40, Kemal, you have to be at least 100 pounds higher than your healthier weight. So if your healthier weight was 150 pounds, when your BMI is 40, the chances are that you are 250. And then BMI over 50, it means 150, 170, 200, 220 pounds higher than your healthier weight.
Can you just repeat that again, like the percentage of that BMI example?
So if you take somebody who is about a BMI of 40, it means that they are carrying 100 pounds extra, 100 pounds more than their healthier weight. So if a person who is, let's say, 5'5" in height has a healthy weight of about 160 pounds, right? When that person reaches a weight of 260, that's a BMI of 40. So they're carrying 100 pounds extra, day in and day out, right? Now, that's BMI of 40. How about BMI of 50? That means 150, 180, 200 pounds higher than their healthier weight. Now, this is not just literally weight that they have to carry on day in and day out, whether they are going to their car or trying to climb stairs or trying to get out of bed or trying to tie their own shoelaces, right? This is a weight also that comes with severe medical problems like high blood pressure, diabetes, sleep apnea, right? These are huge burdens. So a person with a body mass index of 55 is likely to be on multiple medications, is likely to be on a CPAP machine. Clearly, that is a very sick person from a medical point of view. That person is not healthy. So bariatric surgery is not only needed on that person, it's a matter of urgency for that person. Their life is in danger because any of those conditions could really shorten their life expectancy, right? So for a patient with that body mass index to drop from the program is tragic. How are they going to be able to lose that much weight by themselves and become healthy? They can't, right? So when this dropping occurs because of the unreasonable demands that insurance companies have on what patients have to do to be able to get treatment, that is just not right, right? Now, as I said before, Kemal, absolutely, preparation is necessary. Preparation meaning that you have to see a nutritionist so that you can learn about healthy eating, so you can learn about eating habits after surgery. Psychological evaluation is important so that you can come to terms with emotional issues that you may have or you could encounter in the future. Evaluation by a heart doctor, by a pulmonary doctor, and other specialists may be necessary, but all that should not be excessively burdensome in terms of the time it takes for that to be obtained. That is clearly what we see very often. So when patients of that body mass index drop out, Kemal, invariably they will come back to the program unless they have become so sick that they cannot come back again, which is even more tragic. So you're right. When we see patients with that kind of body mass index dropping out from the program, we are concerned and we do everything we can to reach out to them, to help them to get back into the program, essentially. And as you correctly said, the program is not just about surgery. The program is also about knowledge, education, evaluation, which includes often we refer patients who are not ready to have surgery for a number of reasons. And we tell them, okay, stay in the program so that you can see a nutritionist on a regular basis so they can help you, so that we can encourage you to continue to be active physically, so that at least even if the
I lost you for maybe 10 to seconds there. You're not on the Wi-Fi, right? Are you connected? I mean, you're on Wi-Fi.
Me?
Yeah.
Yeah. We got disconnected for some reason. I'm not sure.
We're back to normal now. So I don't know if it's 6 p.m. with the rush hour. That I don't know. But I can see the Facebook Live from the iPad. And it was your picture cut out. I stay there. I don't know. It could be the Facebook rush hour.
Yeah. I actually noticed that your audio also was not coming as clearly as it did before. I'm not certain what the issue was.
Okay, so I'm getting like feedback from the office, and then they are able to. We are going to take for.
I don't think I can hear you very well, Kemal.
Okay, so let's see.
I think we are having some technical issues, definitely.
How about now?
Now I can hear you. Yes.
I think it's the connection going in and out. It may be.
Do you think it's on my side or?
Well, I won't blame you yet. The only thing I was saying that is because it was your picture dropped out when I was looking at the face.
Okay.
I mean, but I think it's maybe related to the Facebook. Our Zoom video looks perfect, so we will be posting it.
Yeah, absolutely.
When I say perfect, I hope people don't misunderstand. So I mean, the quality-wise video looks so good, but course, the content is our patients will decide. Now, Dr. Ergau, let's say we went through the insurance issues and all that. I still see patients, for example, they have some emergencies in their life and they want to stop the process. And my reaction is usually, and you see some of these real time, I'm like, well, yes, you have emergencies in your life, but if you don't take care of your body, you're going to have other emergencies. How do we reach out to this patient? Like, what do I say? I wanted to call some of them, and some of them, of course, we can understand if they have some stuff that's out of their control, and if it's like maybe temporary. But if they just want to hold the process, they went through 60 to 70% of the process, and then boom, they stop, going through the program. How can we actually get them understand? I mean, one of the stuff that we do is these videos, and we are hoping that they can actually watch. But other suggestions that you may have.
So I think it's a challenge. It's a challenge clearly that is, multifactorial, obviously. As you correctly said, there are situations in which, it's unavoidable for patients, but there are other situations in which they should be able to get back to us, and I think having a very well structured like our program helps greatly from that point of view. But nevertheless, even in that situation, we do see the dropout. Part of the reason may be, Kemal, from the really long-term trials and failures that patients have experienced when battling obesity. They do many programs, they do many diets, they go on, they succeed to some extent, and then the weight comes back. That kind of chronic recurrence of the problem without them not being able to get a good handle on this issue is very discouraging for some patients. And as I said, part of the issue is this length of the preparation that is demanded by insurance companies, obviously, is a main issue. So educating, which is what we do, even what we're doing today is part of that, essentially, is to create as much awareness as possible. That is how we can help, right? And the fact that we are available all the time, the fact that we can do telehealth consultations with the surgeons, with the dietitians, that has added more flexibility, hopefully will help us to some extent with this. But I think the fact that patients have been discouraged so many times in the past also plays some role in this issue, Kemal. Now, the other issue, obviously, that we have to consider is that patients may be just scared as well, right? Because surgery is something that opens up different levels of anxiety from patients' point of view. Of course, bariatric surgery has never been as safe as it is currently. Some of our bariatric procedures, like the sleeve gastrectomy, have acquired a level of safety that they're now comparable to things like gallbladder surgery or hip replacement surgery, which are, extremely safe procedures from, compared to the past, essentially. But that kind of trepidation is also part of human nature, and we as providers, we have to educate patients. We have to be able to show them that the short-term risks of surgery, which have been diminished greatly, really are much, much lower when we compare them with the long-term benefits, or when we compare them with the long-term risks of staying obese, right? The long-term risks that may not be immediately visible are the ones that we have to be able to show to our patients. Clearly, as you and I have talked many times, and our patients know, bariatric surgery is something that can never be imposed. A person has to be comfortable with that. But creating that level of awareness, educating patients really is part of our mission, without any question.
So, and the other thing that I am actually proud of our program overall, where we have our care managers and care coordinations, the discipline of having multi-specialty approach, having the system in our ACO mainly, where we are able to actually have good access to patient data, help them with the process of the scheduling. I think, if I was thinking if any of my family members had to go through the program, I would be comfortable just not being involved personally and then just trusting the system, because our care coordinators are well experienced and very knowledgeable. And because we are repeating the same process every day so many times for so many different people, so it does make a huge impact on the outcome and getting the patient through the surgery. So, we want to make sure that these events are helping and supporting those who are going through the difficult times. And we understand that this is difficult. We know that this is not easy, but also if you know that you have a really good team that you can rely on from the surgeon standpoint, from the clinical staff standpoint, and our surgery center right now are 12 months patient satisfaction, we're at 100%. And 90% of those are coming from our bariatric patients.
Absolutely.
And I know that we are, it's almost like a concierge service. I probably can say this, we are almost like the Ritz-Carlton of surgery for bariatrics. So although someone may see this as just any other surgery center, but the personalized care that we are providing from the start to the end, I believe it's priceless, and we are extremely proud of that outcome and what we are providing. Dr. Irgau, would you like to add anything before we sign off?
No, I would like to just say that, morbid obesity is an extremely serious disease. There's no question it's killing us, it's killing our country because it's become an epidemic. And people shouldn't feel that it's their fault and they have to battle it themselves. No, it has to do with the biology that we have and the environment we live, and they shouldn't have to suffer. We're here to help them. We have a great program with very, very experienced surgeons, but well-coordinated program as well that can really help them, educate them, and show them a way out. And there is a way out. There is a way out of morbid obesity.
So, Dr. Irgau, today I just want to make sure that I remind everyone, we also have from our ACO, Accountable Care Organization side, United Medical Wellness Program has an event started at 7. You can find information on CHRIAS and United Medical Facebook site. This video will be posted on YouTube as well as it will be available offline on Facebook. I have another event coming up on Friday. I actually, Dr. Irgau, I forgot to tell you that I'll be on one of the news channel, the Turkish American news channel on Friday morning, right. On the corona updates. And then next week, Wednesday, we'll be back at 3 p.m. And I'm hoping that Facebook won't give us too much issues with that now. So hopefully we are able to help. I'm just going to double check if there are any questions that we didn't cover. I'm just going to wait for Melissa to give me an okay to sign out. Dr. Irgau, I do personally appreciate your time and our other surgeons' time when they actually make these available, because I personally believe that this adds a huge value to the regular office consult. So patients may be with us for, let's say, 25 to 40 minutes in those, but then when they listen to these different episodes of our events, our videos, I think they will learn more and they can actually understand better. So right now I was given okay to actually say that we are good. Again, thanks for joining us, Dr. Irgau. Thank you again, and we will see you soon. Thank you.
Thank you. Thank you. Have a great night, everybody. Thanks.